Welcome everybody to this presentation on celebrating 5 years of the Transform project. I'm delighted to start off the conversation, and I've got with me Sam Zwickl, Charlotte Blacklock, Sasha Bailey, Tommy Ruggles, and Julian Grace. And we're so excited to share some of our key research findings with you. I just wanted to acknowledge the traditional custodians of the unceded lands on which this research has taken place from every corner of Australia and from where we're all currently residing or working today, and we pay our respects to the elders, both past, present, and to any Aboriginal and Torres Strait Islander people with us today. We acknowledge that trans people are ancient. These lands that we're living on are the home of the oldest continual culture and therefore the home of the oldest examples of gender diversity. We can't do any of our work without the support of all of you in the audience. We want to thank the 2,300 trans people who are involved in Transform, which is an enormous number of people who've joined us over the last 5 years. I also want to sincerely thank our wonderful staff, particularly Sav Zwickl, who's spearheaded this project. I'll let them talk more about what they've achieved in the last 5 years. Our wonderful students, many of whom have come for short periods and left, and our many volunteers, some of whom are joining us today, as well as our community advisory group who've provided invaluable feedback. I also want to thank our many collaborators, community organisations, advocacy groups, researchers, clinicians, and our incredible funding bodies, without whom we couldn't do any of our work. We are going to talk about some sensitive and potentially triggering topics, including mental health, suicidality, and experiences of discrimination. We're also going to talk about body parts and processes and talk about medical terms like menstrual periods. And so if this causes any distress, please feel free to check out at any time, leave the meeting or come back. And if you're needing any support services, please just scan that QR code with your phone. So this is what we're going to talk about today. I'm just going to give a brief overview of our research group, and then the speakers are going to speak to these topics listed here. So who are we? I'm a clinician scientist, and I lead the Trans Health Research Group, and together with our fantastic team, we have about 18 to 20 members, staff and students from a diverse range of professional backgrounds. We have doctors, we have nurses, we have social workers, we have osteopaths, we have social scientists, allied health professionals, researchers. Most of our team are trans or gender diverse, and we're all based in the Department of Medicine at the University of Melbourne. We really started not so long ago, 2017, because of three main reasons. There was this huge clinical need for gender-affirming care. No one was providing it. There was enormous barriers to health that we had observed in the community, including barriers to accessing healthcare. And even when people could access healthcare, there was very low levels of evidence to guide healthcare. And so over time, our vision has been for trans people really to live a life without barriers. And our goal for all of our research has been to improve the health and wellbeing of the trans community on the ground. And with community, we have developed three main research priorities, the first being improving mental health and wellbeing. And we've got a number of projects under that umbrella, including this Transform study, which we're going to share more about today. The second priority being improving access to healthcare and improving health service delivery. And the third being better understanding gender-affirming hormone therapy, how to best deliver it, to optimize affirmation goals, and also what are the long-term effects on various bodily systems. So every one of our projects, some of which are listed here, is co-designed, and that means that trans people are involved in the design and the delivery of the research and the translation of the research findings. And we focus very much on communicating these findings back into community via our social media page and our email updates. And you can find us on Facebook and Instagram at Trans Health Research. So today, we're going to share with you Transform, our biggest project within our research group. And I'm going to hand over to Dr. Sav Zwickl, who is going to share some of our challenges and our successes over the last 5 years. Thank you, Sav.
Thank you so much, Ada. It's such a delight to be here, and I can't believe it's been 5 years or almost 6 years with if you include behind the scenes. So yeah, this is such a huge accomplishment to be here after 5 years. It's certainly one of the biggest projects in trans health this country has ever seen. in 2019, Ada came to me. I just joined the team. We were a much smaller team than the 18 or 20 people we are now, and had this idea of creating what we call in research a longitudinal project. So that means something that's longer term and ongoing, where you can follow the same group of people over time and monitor for changes in things like mental health and health conditions. We didn't want it to be like your average study. We wanted something special. We wanted to create a community around research. And so what ended up evolving was these 4 guiding principles which have guided how we conduct the research and make sure we stay true to what we intended from the beginning. And so the first is trans leadership. There's certainly a history within trans research of it being dominated by cisgender people. Sometimes it's been quite pathologizing of trans people. We really believe that trans people as researchers have this insider community knowledge that can help to facilitate rapport with trans communities and lead to a more immersive and reflexive research experience and approach. And so Transform has been led by trans people throughout the last 5 to 6 years. And we want a community to be involved in the research process as much as possible, what is called in research co-design. We did that in a number of ways. We developed a community advisory group of 8 different individuals from across Australia with a particular focus on making sure people like Indigenous trans folk and neurodivergent trans folk and trans folk living in rural Australia were represented so that their priorities and their needs are seen in the research. We work closely with community organisations, those who are in the front line day in, day out, working with the trans community, hearing all their stories and making sure the research is not on this niche topic of interest, it's really hitting on the things that we need most as a community. We work with specialist clinicians. You'll hear about that a little bit more, particularly like in Julian's study, which was on pelvic pain, where we work with gynecologists and physios. We get a lot of feedback from Transform participants as well, which has been really, really lovely. Another guiding principle has been access to research, making research more accessible so that anyone that wants to access it can, particularly trans people. And I'll talk a little bit more about that at the end of this presentation, how we've gone about doing that. And we don't want to just do research for research's sake. We want it to have a real world impact. Again, we'll talk about this a little bit later, the way that we approach stakeholders to ensure research doesn't stay in that academic bubble, that we're reaching the people we need to reach, the decision makers. So this is an overview of what Transform looks like. On the left, you've got all the different people that are involved in making decisions. We come together, we identify community priorities, and then we design studies from there. We've gone to 3 ethics committees for all our studies. That's Austin Health, Thorn Harbour Health and ACON. And the reason that we do 3 instead of just 1, which would be the minimum, is that it's extra eyes over the study, particularly community members as well. And they give us really great feedback. And as I mentioned, participants have the opportunity to provide us feedback in each of the studies we do as part of Transform. That has really helped to shape the study so that it continues to improve and be more and more inclusive and accessible as we go along. Transform has had ongoing recruitment since May the 1st in 2020 when we launched 5 years ago. We recruit mainly through social media and through clinics across the country, particularly clinics that serve the trans community or doctors that see a lot of trans patients. We have quite a lot of doctors that often refer their patients to check out the studies. So that has been really, really great. Unlike a one-off survey, people complete an enrolment survey. We collect some basic demographic information as well as their email address. And what we can do with their email address then is send them invites to complete sub-surveys as part of Transform each year. There's usually between 1 and 3 sub-surveys. They're all voluntary. So if people don't want to do them, they ignore the email, but if it's something that's of interest to them, they get to be part of that. And as well as provide them research updates, publications, media, and any stakeholder engagement so that they're not giving 20 minutes of their time to a survey, never hearing the outcomes. We want people to see what their time and their energy and their stories have gone to. So since we launched 5 years ago, we've covered a range of trans health topics. A lot of it's been around mental health, particularly around the pandemic in the early years. We've looked at testosterone and pelvic pain and menstruation, which Julian's going to talk about a little bit later, estradiol levels and wellbeing. We've looked at community terminology, which I'm going to go into in a moment. looked at non-binary gender affirmation, suicidality support. Charlotte's going to introduce you to the Gender Euphoria scale. Sasha's going to talk to you in a moment about sports participation. And we ran a study last year looking at housing, financial strain and unemployment, as well as anti-trans media and events and the impacts of those on mental health. So just a few key highlights from the last 5 years. We've had over 2,300 people from across Australia be part of this study. Some have done maybe just one of the sub-studies. I know some of you have done 3, 4, 5, 6, which has been incredible. We've published 11 peer-reviewed publications. We have one community report, the Trans in the Pandemic report, which was a beautiful opportunity. People submitted photos and stories from their experience in the pandemic. 10 research blog posts, which are translations of our research into lay language. The world's first study on the impacts of the COVID pandemic on trans people. World first gender euphoria scale, and we've had the opportunity to inform health policy and fundings for trans health and support services. So from all those studies and publications, we're going to share with you a few of those, particularly the newer studies that have recently been published or things that we haven't had a chance to talk about as much, as well as the pelvic pain and menstruation study that Julian's going to talk about is one of the ones that get so much interest, perhaps more than any of our other studies. And so we thought it'd be a good chance to revisit that study as well. So before handing over to some of the other speakers, I'm just going to go through a study that we did on language and terminology at a community level, because it seems like a good place to start. What kind of language do we use for the community? You may have noticed there's not really a consensus around community level language that we use for trans or gender diverse people. You might see trans and gender diverse, you might see people use trans and non-binary or just gender diverse, and that can have an impact on who feels included within a group, or in, say, a research setting, when you're putting out a research flyer or a policy, who's actually included, and does the language impact who feels they are part of that or who might be covered under a policy. And so we asked Transform participants what resonates with them as the most inclusive term or an umbrella term for the whole community. We gave people 22 common options, as well as an option for like writing a free text response. And then we asked them, tell us why you chose that as the most inclusive or encompassing option. 1,023 people responded. That median age was 30. 3.9% were Aboriginal or Torres Strait Islander. And you can see from the pie graph that there's a pretty even spread between trans women, trans men and non-binary people, and a few people who have a culturally specific gender identity that doesn't fit into those three categories. Overall, the most preferred umbrella terms were trans or transgender and gender diverse, followed by trans or transgender, and then gender diverse. And there's some other common terms or phrases that you'll see pop up quite a bit that weren't much preferred. So transgender, gender diverse and non-binary was one of them. Only 6.7% of people felt that was the best. And only 3% felt that trans and non-binary was the best. As you can see, it's pretty spread. So again, no consensus, no majority saying this is the kind of language we need to be using. We looked at the data by gender and we found some interesting patterns there. So firstly, looking in the middle at transgender, we found that those with a binary gender, so trans men and trans women, were more likely than non-binary people, which you can see in that greeny yellow colour, to say, yeah, trans or transgender is the most inclusive term. Non-binary people, however, about 1 in 3 said that trans and gender diverse is the most inclusive term. And there was only about 4 people with a culturally specific identity, so it's hard to generalise from that. But 3 of the 4 said gender diverse was the most inclusive. None of them chose trans or transgender as the most inclusive. So then we also looked at it by the type of hormones or surgery that people had or were interested in, and we found patterns here as well. So what you can see in the dark green is people who did not want hormones. So they were much less likely than any of the other groups to say, yep, trans is the most inclusive term, but more likely to say trans and gender diverse was the more inclusive term. Whereas those who had or wanted hormones or had or wanted surgery were more likely to say that trans was the most inclusive. So we'll talk about this a little bit more in the moment, but I think that is reflective of the medicalisation of trans and who feels that they call themselves trans. So when we asked people to provide an explanation, it became clear that there's really inconsistent or no single understanding of what trans or transgender actually means. And so that had implications for, well, what's the most inclusive term that should be using. So one of the themes that came up was around this idea of inclusivity. Who's going to feel most included, or how many people are going to feel included by a different term? So one of the ideas that came through was that trans or transgender was really important as a single term for solidarity, for policy and advocacy. Whereas others said that deviation from that standalone term could contribute to loss of nuance or division with the communities. There was also recognition, though, that some people don't fit or don't identify with the term trans, and so maybe trans and gender diverse or some other variation is more inclusive, as well as recognition of trans or transgender as a Western term and notion, and so the need to consider people from other cultural identities and where they fit and what is the best language to be using. Another theme that came up was trans as a binary and medicalised experience, that trans as a term was only reserved for people with a binary gender identity, or only reserved for people that engaged in some kind of medical affirmation. And lastly, this consideration too of broader societal understanding or accessibility to language, as well as destigmatization through language as well. Where that leaves us is probably the same place as we started, in that there is no clear consensus around community level terminology, and it's something that I feel is really changing really quickly on a global level. There's certainly more we can explore in this area, and I think it's something we need to continue to touch on to ensure that people feel included by the language that we're using. Things to explore too, things like acronyms or initialisms, as well as highlighting the experiences and perspectives of Aboriginal and Torres Strait Islander peoples and people of non-Western cultural backgrounds, and how they see themselves fitting within community and what language they want used as well. So that's it from me. I'm going to pass over to the wonderful Charlotte, who is going to talk about the creation of the world first gender euphoria scale. Thank you so much, Charlotte. It's been a pleasure to work with you.
Thanks so much, Sav. So I am Charlotte. I use she, her pronouns. I'll be speaking today very briefly about the gender euphoria scale, which was co-created by myself, Sav, and Ada, as well as my supervisors. There are lots of them, so bear with me. Ken Pang, Michelle Tollett, Carmen Pace, Brad Alphenstone, and Simone Buswell. And the scale was also created by our collaborators in the States at Duke University, Kira Citron, Sam Marsden, and Nancy Zwickl. So I'm privileged to be representing a team of people who contributed to this study. Okay, thank you. So gender euphoria is, of course, a concept that arose from within the trans and gender diverse community to describe positive gender-related experiences. Gender euphoria has been described as feelings of joy, contentment, comfort, freedom. It's a very subjective experience encompassing all sorts of good feelings, and occurs in the context of gender expression, gender affirmation, and gender identity. However, despite gender euphoria being a really significant construct and concept to a lot of trans and gender diverse people, there's never been a consistent, valid, or reliable way of measuring gender euphoria. So with this in mind, we set out to develop the gender euphoria scale. In our study, we had 664 kind, generous, and patient truly, because it was a very long survey that we sent out, transform participants who ranged in age from 16 to 79. In our study, we also had a relatively even split between trans men, trans women, and non-binary people, with a small number of people identifying with a culturally specific gender identity. Most of the participants had experienced gender euphoria, almost everyone, in fact. Many participants had experienced gender euphoria almost weekly or daily, and most rated their gender euphoria as being moderate to very strong over the past year. So in other words, this was a very gender euphoric sample. Okay, so I'll briefly talk you through the process of developing this scale. We started off with a working scale made up of about 120 items. And those items came from some previous research conducted in the States by our collaborators at Duke University, who did some qualitative work looking at gender euphoria in a US sample. We knew 120 items was perhaps a few too many. So we went through a process of reviewing and refining the items. And to do that, we engaged in a process of consultation with some clinicians working at the Royal Children's Hospital Gender Service, and also with the Trans Health Research Community Advisory Group, who provided so much useful feedback and really helped us to shape the scale so that it was ready to be sent out as part of a survey. We then, and that's where probably several of you come into this, we sent out the scale to, well, we invited everyone, all Transform participants who wanted to do it to participate. And we invited participants to complete the scale on 2 separate occasions. We then analysed the data and created the scale, which I'll speak to right now. We ended up, through our process of analysing the data, with a 26-item scale, and we identified 3 separate subscales. So the first of these was a social affirmation subscale comprising 14 items. And this is a subscale that refers to gender euphoria occurring in the context of being affirmed primarily by other people. So that might be family or strangers, but also includes legal documents. So having legal documents that accurately reflect a person's gender. We have the self-affirmation subscale comprising 4 items. So this subscale measures gender euphoria occurring in the context of one's physical appearance. So for instance, when looking in the mirror. And the third subscale is about community connection. So this is 8 items that relate to gender euphoria that happens when trans people connect with other trans and gender diverse people, or when seeing other trans and gender diverse people represented, for instance, in the workplace or on television. So that's the scale. Obviously, there's a paper that goes into a lot more detail and describes the items in their entirety. But for those who like statistics, which is probably quite a small percentage of people, the gender euphoria scale has excellent internal consistency, strong test-retest reliability, and some evidence of discriminant and convergent validity, but further validation studies are probably needed. So we have created the world's first tool to measure gender euphoria, which is very exciting. And I just want to thank everybody who contributed to this, not just the co-authors, but of course the participants. This scale would not exist without you. And we really hope that this scale contributes to a more holistic understanding of trans people's experiences and lives more broadly. And we also hope that it will be of value in research, mental health, gender-affirming care, and community settings. Thank you.
Thank you so much, Charlotte. As I said, it was such a great experience to collaborate with you and everyone that works around you. It's been such a, exciting thing to be a part of, and for Transform to be a part of as well. So now I want to hand over to Sasha Bailey, who's going to talk us through a study on sports participation and covering 2 different publications that we've had out in the last year or so.
Thanks, Sav. Yeah, so it was on the heels of a steep rise in anti-trans media and rhetoric around trans inclusion in sport that Sav, Ada, and I and many others connected and really put our heads together to work out what we could do to use research to advocate for our communities. There's very little research examining the mental ill health outcomes associated with the multiple unique and common barriers that trans folks face accessing sport settings. And so with Transform, we aimed to explore those barriers, namely those internal barriers, external barriers, and bullying experiences in terms of prevalence, but then also looking at how those were associated with mental health outcomes. Importantly, with Transform, we were really lucky to collaborate with Ryan Storr from Swinburne, as well as Bo and Emma from Pride in Sport, and also Ben Trevor from New South Wales Health. So this is our sample. We were really, really fortunate to get just under 700 folks responding to the call. Median age was 32. Like Charlotte's study, it was fairly equal split across trans men, trans women, non-binary folks, with a very small percentage of folks with culturally specific gender identities. And owing to the strength of Transform and the team, we were really lucky to get representation from all Australian states and territories. So this diagram summarizes. So it's a bit hard to compare how we measured sport participation with general population available statistics, but noting that caveat, you can see here that in our survey, we found that only 1 in 3 trans folks reported regular current participation in sport. And that could be team sports, it could be individual sports, or it could be fitness activities like going to the gym or solo things like walking. And we compared that to the Clearinghouse Sport database, which suggests that 70% by contrast of people in the cisgender mainstream population are participating. So yeah, less than half, relatively speaking. So these are those internal barriers, external barriers, and bullying experiences that we surveyed. The most common internal barriers are in the blue, and those were body dysphoria, anxiety about others' reactions, and fears about being accepted and affirmed. In terms of those external barriers, those system-level environmental factors, bathrooms and toilets, were a very common challenge faced by participants, but also exclusionary gender roles. A large proportion of folks reported exclusionary gender roles. We looked at bullying victimization from a range of perpetrators, including team members, parents of team members, venue staff. Here you can see we combined all of those, and you can see that 1 in 3 folks in this study reported ever being bullied or excluded based on their gender in a sports setting. So then we further broke it down by gender, and it was not surprising, I suppose, but very stark to see that internal barriers and generally barriers and bullying victimization experiences were most common among non-binary folks. That was true for internal, external barriers as well as bullying. Then we looked at associations with mental health. Here, this refers to any lifetime experiences of internal barriers, irrespective of whether folks were currently participating in sport and fitness or not. And we found that any exposure to any internal barriers, and there was about 8 that we compiled a list of with consultation with the advisory group as well as amongst ourselves. And we found that psychological distress was a lot higher with internal barriers and external barriers, as well as any bullying experiences, regardless of the identity of the perpetrator. Similarly, we found that any exposure to internal barriers increased the odds of suicidal ideation in the preceding year. Any exposure to any external barriers was associated with a higher odds of suicide planning in recent times. And any experience of bullying or exclusion based on one's gender increased the odds of folks reporting suicidal ideation and suicide planning in the preceding year. We also then looked at sport participation, trying not to focus on the mental ill health outcomes associated with the adversities faced by folks. And importantly, we found that regular sport participation within the sample of trans folks was associated with lower psychological distress, lower odds of suicidal ideation in the previous 12 months, and lower odds of suicide attempts in the preceding 12 months, very much consistent with evidence from mainstream cisgender populations. And so in this study, we found relatively low rates of sport and fitness participation among trans Australians, noting that common experiences of barriers and bullying exclusion are very much a reality for lots of folks. And these are indeed associated with higher odds of mental ill health outcomes. But importantly, we need to keep promoting trans inclusion in sport, because sport and fitness participation is associated with reduced mental ill health.
Thank you so much, Sasha. So now I want to introduce you all to Julian Grace. Julian has been a researcher with Trans Health Research Group for quite a long time and also works as an osteo. And so their clinical experience feeds a lot into their approach to research. And so looking forward to hearing from Julian about pelvic pain and menstruation in trans people using testosterone.
Thank you, Sav. So yes, I'll be talking about this paper from 2023. I feel like I should disclose at the beginning that I wasn't an author on this paper, and I'm so impressed at the work of everyone who was part of it, and I'm very honoured that I get to have this opportunity to share it with you all. Pelvic pain is very common amongst trans people using TE, testosterone, but it's poorly understood. So as a starting point to better understanding this topic, our team collaborated with gynecologists Charlotte Elder, Sonia Grover, and pelvic floor physio Laura Birchall to design a survey that explored testosterone use, menstruation, pain experiences, and relevant diagnoses in trans people who are using testosterone. So there were a total of 486 trans people who currently use testosterone who completed the survey. 77% were trans men and 23% were non-binary. The median age was 27 years, and the median time that they'd been using T was about 2.5 years. So as you can see, 72% of participants reported having experienced some kind of pelvic pain after initiating testosterone. But it's important to know that almost every single person, it was 98%, reported pelvic pain after starting testosterone, also reported experiencing it prior. So we can't really describe it as new onset. In terms of pain intensity, on a scale from 0, which is no pain, to 10, the median rating of pelvic pain while using testosterone was 6.2, which is thankfully slightly lower than the 6.7 that people reported experiencing prior to testosterone. So as well as looking at how common the experience of pelvic pain is after T, we wanted to go a bit deeper and ask people who experience that pain what kind of pelvic pain they're experiencing, the quality, the intensity, and where they feel it. And because pain is complex and subjective, obviously participants were able to select multiple options. And the most common ones were cramping, aching, stabbing, and sharp pain. On the right there, you can see a diagram of typical abdomen split into anatomical regions. And overall, the lower abdomen was the most common by far, but particularly the middle, so that hypogastric region roughly between the belly button and the pubic bone. So, expanding on these questions further, we wanted to explore whether some other experiences or issues might be associated with higher odds of reporting pelvic pain with testosterone use. So we looked at a whole range of things that might have been possible, drawing on clinical knowledge from the authors and also community perspectives, but found no association between reporting pelvic pain and the length of time on T, issues like genital dryness, body weight, intrauterine device use, previous pregnancies, any pain with penetrative sexual activities or touching of external genitalia, and no association similarly with diagnoses of endometriosis, vulvodynia, vaginismus, depression, and anxiety. This study did show, however, that there were 3 factors associated with higher odds of participants reporting pelvic pain. So if their periods hadn't stopped, if they had persistent menstruation, if they had pain with orgasm, and if they had some sort of experience of post-traumatic stress disorder. So the association with persistent menstruation is really interesting, and also pain with orgasm, because we know that pelvic floor muscles are hormone sensitive. So this suggests that pelvic floor muscle dysfunction might be a contributor to pelvic pain for trans people who are on gender-affirming hormone therapy, testosterone. Exploring all these potential factors that might be associated with pelvic pain gives us a better understanding of what the underlying cause might be and ways that we could try to approach treating it. So given the associations identified in this study, including PTSD, it's pretty obvious that a tailored, multidisciplinary and trauma-informed approach should be offered. So this could include things like pain management, sexual function, addressing persistent menstruation, and also mental health support. We've also got another paper called Persistent Menstruation in Transgender People Using Testosterone Gender-Affirming Hormone Therapy from 2024. So essentially, following on from the previous study, we used the same data from the same survey to look more closely at this specific issue. Menstrual suppression or stopping periods is a highly desired effect of testosterone, but we don't know much about the process or what factors might lead to periods stopping or not, or persisting. So data from the pelvic pain survey was used to explore menstruation before and after starting testosterone, the details of that testosterone use, and also any relevant diagnoses. And shout out again to our collaborators on this, the same as the previous. So we looked at the sample from the pelvic pain study, and in order to make closer explorations and look at menstruation, we added some extra participant criteria. So there were 401 people involved in this study as a result, who experienced menstruation before starting testosterone and had been on T for more than 6 months. We asked participants how long it had taken or if their periods had stopped after starting testosterone, and found that 3 in 4 participants reported their periods stopped within the first 6 months. However, persistent menstruation, so for the purposes of this study, it was defined as any menstrual bleeding that continued beyond 6 months past starting T, that was actually reported by 23% of participants. The team then looked deeper to see if there were any patterns that could be identified in the data, and found that the age that someone started T, the regularity of their periods beforehand, didn't actually seem to affect their chances of their periods persisting. What we did find is that participants using testosterone as creams and gels, so topically on the skin, were more likely to be experiencing persistent menstruation than people whose T was given in injections. So what can we take away from this? The association between topical application of T and persistent menstruation in this study might be telling us that gels and creams are achieving lower testosterone levels than injections, which could be contributing to persistent menstruation. I'm using a lot of qualifiers like may and could because we can't make any definite claims about causality from this study. But the results suggest that switching to injections could be an option worth considering for this population, and can hopefully offer GPs and other prescribers a little bit more knowledge and more tools to discuss this issue with people. So we hope to see more research in this area in the future.
Thank you so much, Julian. Like I mentioned before, the stuff around pelvic pain and menstruation has been of particular interest to the community, and certainly, you know, spending time in community online groups and stuff like that, in trans mass groups, it's one of the most common questions that comes up. So it's been such a great thing to have done research in this area and to be able to point people to, hey, we've actually got statistics on this now. So to finish up, because I know we haven't got too many more minutes on the clock, I just want to talk you through briefly what we plan for Transform next and a little bit about the impacts that Transform has had. There's a few things that we're looking to do next or to finish up. We interviewed a bunch of people in 2022, 2023 around their experiences of suicidality and helpful and unhelpful responses they received and their experiences with mental health professionals, including hospitalisation in some case. And we're really hoping to publish that work as soon as possible. The other thing that we're working on, like finishing up analysis and reporting on, is the biannual mental health survey that I mentioned earlier, where we explored housing and unemployment, anti-trans rhetoric and policies and violence, as well as looking at healthcare experiences. So we've got a lot of data from just last year that we're hoping to get published as soon as possible, particularly on those issues of things like housing and anti-trans rhetoric, because they're just so pressing. We've also got another study that's due to launch in the next couple of weeks. So for any Transform participants, keep an eye on your emails. That is a study led by one of our master's students, looking at desires for and motives for gender-affirming care, and particularly those people who desire or pursue non-traditional or non-standard approaches to gender affirmation. So we'll be sharing more information about that soon with our Transform cohort, which is really, really exciting. Lastly, just looking at research reach and impact. Like we said at the start, one of our core principles has been around ensuring people have access to the research. And we want to do that because it's important to elevate trans lived experience and to provide accurate information and accurate stories, particularly in this area of disinformation. We want to make research as accessible as possible. I'm going to talk about some of the ways that we do that in a moment. And we want to show people that they aren't alone, particularly around challenges that we experience as trans people, that they're not alone. It can be really helpful, I think. So some of the ways that we share our research, as I mentioned earlier, we provide update emails, usually 2 to 3 times a year, to all Transform participants, so the 2,000 plus people. In those, we provide access to any of the publications that have come from Transform, updates on any media coverage, any major things that have happened in terms of stakeholder engagement or funding or stuff that's come from the research. Also social media, so we're really active on Facebook and Instagram. I find it a really great way to share little snippets of information from the research, including things like people's quotes and particularly the positive stuff as well in this world that we're in at the moment, where a lot of stuff about trans people is negative. It's great to show some trans joy and euphoria. Our research blogs have been really, really popular. Like I mentioned before, our pelvic pain blog in particular has had over 40,000 views since we put it up on our website. And I have doctors telling me quite often that they send a lot of their patients who are using testosterone to that blog for information in a really easily accessible way that we've written it. And so on our transresearch.org.au website, there's a blog section. You can find all those blogs there. We often write a blog that's released at the same time as a publication with easy to understand version of the key findings. We've engaged with media quite a bit over the last few years. Pretty selective with who we engage with as well. You do have to be careful, but it's been a great way to reach people beyond the project and our little social media bubble. And just recently, with the release of the Euphoria scale in the last month, there was quite a bit of media interest around that as well, which is really, really great. Engaging with stakeholders. So we do quite a lot of behind the scenes work. So not just collecting the information, but making sure it gets to the people that matters. That's included engaging with federal, state and local government, community organisations, mainstream mental health organisations, healthcare professionals. We provide as part of our research group training for healthcare professionals, as well as sporting bodies. The sporting data that Sasha presented has been also presented to the International Olympic Committee, and AIDA does a lot of work particularly around sports inclusion with sporting bodies internationally and in Australia. You know, with all the stakeholder engagement or the media engagement that we do, we're always looking to highlight community priorities, make recommendations based on the data, and to advocate for funding and for services for trans people and for change in policy and practice. And it's been great to see some of the transformed data used to support anything from big policy, like the New South Wales policy you can see on the screen, Commonwealth government. We went to the House of Representatives with some of the data as well as like I sometimes get emails from small scale little community orgs that have said, oh, we use your data for such and such and we got a $3,000 grant or whatever. It is so wonderful to see the data show up in different and sometimes really unexpected places. So that's it from us. We do have a few minutes on the for some questions. On the screen, you've got a few different QR codes. If you do need support, the QR code on the top right takes you to a link on our website with lots of different trans-affirming resources and services. You can download a report to mark the first 5 years of Transform. And if you haven't and you are eligible to be part of Transform, we really would love for you to join us. We so deeply appreciate the stories and the time and everything that people share with us, and really try to do our best to honour that and to see it through and hopefully have an impact and improve the health and wellbeing for our community. So I might stop sharing and open up for a few questions. I have seen already a few in the Q&A, so let's have a squiz. We did have a question. I think this probably relates to the language paper. Someone said, was there any sentiment about whether transgender and transsexual were useful terms for distinguishing between social and medical transition? I think one of the, and it's kind of reflective of the time that we did the language study, because I think we would have done it differently now. And that was, we didn't distinguish between transgender and trans as potentially different terms. And so it'd be great to see future research, and certainly with conversations that we've had in our team and from community, and I've seen some of the, responses that have come through from participants as well, that have said, trans rather than transgender, it could be a more inclusive term for transsexual people who identify specifically as transsexual but not transgender. And so in the language we use in like all our, on our website and in our social media tends to be trans and gender diverse, very specifically the trans part to be more inclusive of transsexual people. And I think off the top of my head, I want to say about 6% of the transform cohort identify as transsexual. So we don't want to be like some other groups who just dismiss it as outdated and offensive, because we do know for some people it's a really important part of their identity. Okay, will there be opportunities for face-to-face meetings in Sydney? I'm not sure if you mean like seminar type things or in terms of research. So in terms of seminars, we did previously do some stuff in person before COVID in Melbourne. Because it is a national study, the benefit of doing it online is we get to record it quite easily for people to view time and time again, but also to reach people in as many parts of the country as we can. If you're talking about research, so Transform has always been online and has always been national. Our research team does do other research, clinical-based research, and most of that is based in Melbourne. I don't know if you want to chime in on that, Ada, at all.
No, some of our prospective clinical trials and things, we are recruiting people who need to come in to have like a medical assessment or some various tests. And for that reason, we have sort of local sites only in Melbourne. We are starting up a site if we can get funding in Brisbane, and it all depends on funding. So we're certainly trying to apply for funding for various research projects.
Right.
Can I jump in with that one, Sam?
Oh, yes.
Sorry to go rogue, but if people wanted to be able to chat with us about our research and have that more informal, in-person getting together, the OzPath conference is in Hobart, Nipaluna, in November, and a lot of us will be there. So that is my spruik for that being a good opportunity.
We can probably take maybe one more question, and that'll be for you, Charlotte. So Chrissy says, really excited to learn more about Gender Euphoria Scale. Has there been much uptake from medical bodies?
Thanks for your question. To be honest, I don't know about uptake, but there definitely has been some interest. We've definitely had people working in gender-affirming medical care ask us about access to the scale, and Ada did answer a question previously about accessibility and was right in saying we're currently trying to make the scale freely accessible by upgrading it to open access, but my email is open and I'm happy to send out the scale to anyone who wants it in the meantime. So yes, there is definitely interest. How long it will take to actually show up in medical settings, I have no idea. It's out of my hands, but hopefully sooner rather than later.
Thank you. We have one more, we probably can address one more thing, and I think it's a perfect way to finish. And I do acknowledge there's a few unanswered things there, but we should be able to follow up with you afterwards. So someone was just asking, wondering if there's an opportunity to contribute to this great work. So various ways that you can contribute. Firstly, promoting this Transform. So on the website, you can go to participate in research section where there is a Transform webpage. And on there are social media tiles, there's printout posters. You can share through social media to promote. It's an ongoing recruitment process. We don't have a end point for Transform at this stage. So it definitely helps to get more and more people involved and just promoting the findings as well. In terms of if you're interested in being engaged in the research and coming on board like in a volunteer capacity or something like that, you can certainly send us an email. So we can pop that in the chat as well before we go. But yeah, always welcome people to reach out, whatever concerns, questions, anything, please reach out. We are always happy to hear from you and to particularly when it's going to improve the inclusivity and accessibility of the research. So we may have to finish up there because I know people have probably got places to be, but thank you so much again to everyone. It's been a massive thing, and some of you have given so much time, like, you know, voluntarily. So I think we've created something really, really special here, and I know we're really, really proud of it. And yeah, thank you very, very much to all of you.